Thank you, everyone. Thank you, my respected seniors, my teachers, my colleagues, dear colleagues, and my beloved juniors who are studying in different DM and DNB courses. So this is our usual program we are having from IHRS, the virtual arrhythmia meeting, for last at least 2 years. And we have covered almost most of the topics which are very important for the DM and DNB trainees. This meeting is somewhat special today because it is mostly done by members who are in the executive committee of IHRS. And we have also selected some very important topics which are very illustrative, and we have very good speakers to deal with those topics. So I think for one announcement is there that everyone should be on mute except the moderator, the speakers, and the faculty. Other than that, everyone should be mute so that we don't have any audio interference during the meeting. So I think without much prolonging this discussion, I will invite Dr. Ashish Navar sir, consultant electrophysiologist, senior consultant electrophysiologist in Maharashtra, Mumbai, and to speak on anatomy of the cardiac conduction system. Sir, please.
Yeah, thanks, Suchit. As Dr. Mazumdar explained, we have been able to get this program going every first Sunday of the month. And the IHRS faculty has been very willing to, come on board with good presentations that are suited to the interests of the DM-DNB. Can I share the screen? Is it visible, Suchit?
Visible, yes, sir. Your screen is visible.
Okay. So actually, the first presentations from Dr. Pandurangi and Dr. Rakesh Yadav were going to deal with the conduction system. And I thought that it is appropriate to start with something simple. It might seem a bit that this topic is coming at the end of a 2-year program, but I think all the same, all of us should be a little conversant, the postgraduates, with the anatomy and physiology of the AV conduction system. Of course, you can't deal with it in great detail in the 15 to 20 minutes that we have, but I just wish to make some general remarks. So as we go through this presentation, it is easily understood that the myocardium of the heart is different, and the main job of the myocardium is to create contractile force, whereas the specialized myocytes which form the conduction system are supposed to conduct the electrical impulse and deliver it to the myocardium. So in that hierarchy, we have the sinus node and the AV conduction axis. And importantly, the role of the conduction system is to have some delay between the atrium and the ventricles so that the atria can adequately fill the ventricles to create the required stroke output. Let's start with the sinus node. This is obviously the primary pacemaker, and therefore this can generate the highest number of impulses, and therefore that is the master of the electrical system. It's located at the junction of the superior vena cava and right atrium, and the size is pretty large. I mean, it's about 15 millimeter. So you can't, like the AV node, even by design, ablate the sinus node so easily. So when you're dealing with, say, tachycardias around this region, it would be pretty safe. It's pretty large structure. And also the normal exit of the impulse from the sinus node can be from different sites in this entire sinus node, and therefore some variation in the P wave morphology would be expected depending on where the impulse exits from the sinus node. The sinus node description came back way back early in the previous century by Keith and Flack. But there are two important aspects of the sinus node that you should remember. One is the blood supply, which is 50% of times from the right coronary and about 50% of the times from the circumflex. So basically an inferior wall MI involving that particular artery with the proximal occlusion can always affect the function of the sinus node, creating bradycardia. Again, there is a rich autonomic innervation to the sinus node. So for example, if somebody has a, say, hypersensitive thyroid sinus, you can easily give a light pressure on the sinus node and show that the sinus bradycardia followed by hypotension comes in. So that's a little bit of a clinical application to know that the sinus node is quite richly innervated by the autonomic nervous system. Here is a picture that shows you that the right coronary artery often gives the sinus node artery. Yeah, sorry, here gives the sinus node artery from its proximal part. Then the impulse spreads from node into the atria. So although there is not a specific conduction system in the atria, probably there are preferential pathways which take the impulse from the sinus node through the atria towards the AV node. There is also intra-atrial spread of the impulse because of these preferential pathways, and also the impulse is directed to the AV node. So basically we have what is called as a Bachmann's bundle. So this is a preferential pathway situated at the roof connecting the RA to the LA. And probably there is also a specific preferential pathway at the level of the coronary sinus ostium. So one can understand, depending on the way the left atrial activation happens preferentially, if it is from the coronary sinus, then the terminal part of the P wave could be negative. If it is from the Bachmann's bundle, then the left atrium would be activated craniocaudally, and therefore the terminal part wave would be positive. So it's good to know that there are preferential pathways directing the sequential activation from the RA to LA. Some would also believe there is some preferential pathway at the fossa ovalis, but these are best called as preferential pathways rather than a specific conduction system. Now, way back again, early in the previous century, you must know this name very well. So now Tawara, he was the one who described for the first time that there is a special conduction system, and that's the only way the impulse travels from the atrium to the ventricles. The annulus fibrosus at both the AV annuli would normally not allow any conduction across. And this AV conduction system is made of the, as you all know, AV node, his bundle, then the bundle branches, and the Purkinje network. Let's kind of shortly look at a couple of things which have relevance to arrhythmias and electrophysiology procedures. So now AV node is in the triangle of Koch, and all of you might be asked this question a number of times in your vivas or in short notes as to the importance of triangle of Koch. It's very nicely shown in this picture. The anterior border of the triangle of Koch is by the tricuspid annulus, its septal aspect then, or septal tricuspid leaflet that is attached there. There is a muscular ridge called as tendon of Todaro, which makes the posterior limit, and inferiorly the coronary sinus makes the inferior border of this triangle of Koch. So you can once again see here the anterior by the septal tricuspid leaflet, the posterior by the tendon of Todaro, and the coronary sinus os. Now, AV node is variably situated in different places in this triangle of Koch. Sometimes it's superior here, sometimes it is inferior, and therefore it creates some difficulties when one is trying to do what is called as his bundle pacing. So locating the AV node there or his bundle there is a little difficult because of the variation in the position. Now, from the atrium to the AV node, the impulse probably conducts to some kind of a transitional cells that are there between the atrial myocardium and the compact AV node, that is, as it is called. So this is the compact AV node. So there are probably some transitional cells which facilitate that conduction. And as I said in the previous some time back, that there is a delay of conduction of impulse from the AV node. If the atria and the ventricle were to contract simultaneously or very rapidly one after another, if there was no PR interval, you can understand that the filling of the ventricle from the atria would be hampered. So the AV node delay provides this mechanical benefit. Again, both the AV node is also very well supplied by the autonomic nervous system. It's quite under the its blood supply is also important to know. About 85% to 90% of times, it is the AV nodal artery. You can see that this AV nodal artery comes from the right coronary artery almost 85% of the times. 15% of the times it is from the circumflex. So the proximal part of the AV node might be purely supplied by the AV nodal artery, but the distal part is usually has a dual blood supply. So that's again something important to know. And the clinical equivalent of autonomic innervation is probably very well known from the carotid sinus massage. You must have had these patients with SVT in the in the EMS, and you know that they are best terminated. Probably the right vagal innervates much more strongly the AV node than the left, and therefore your right carotid sinus massage is the first side that you attempt to terminate the AV node by enhancing the parasympathetic stimulation. Then coming down the conduction system, you have the bundle of His. Once again, this bundle of His is a solitary strand of specialized myocardium. It's a specialized myocardium. It's important to know that it is insulated by the fibrous tissue, so that allows rapid conduction. And there is a histological difference between the AV node and the His bundle. And what that difference brings is that while AV node allows a slowing of conduction or a decremental conduction, the conduction through the bundle of His is like Purkinje, very fast, say something like 2 meters per second. So that is the certain aspects of bundle of His that differ from the AV node. Now again, it's a very small structure, so that's where I pointed out that the difficulty in exactly localizing the His and doing the conduction system pacing by stimulating the His bundle, but we talk of it maybe sometime later. Now there are three portions of this bundle of His. If you look at it, this is traveling a little bit infero-superiorly. So the first part is the penetrating bundle of His, so this one. The second part is the non-branching portion, and the third part is one that branches to give a left bundle and a right bundle. Now, this penetrating lower portion is in relation to the mitral valve. So many times this gets injured when a mitral valve replacement is done. The non-branching portion is at the interventricular crest. This can get injured when inlet VSD is closed. And the third part is the penetrating, and this often can get injured when the aortic valve replacement is done, and the surgeon has to do some good debridement of the calcium there to fit in that aortic valve, prosthetic aortic valve. So this gives you some understanding of which cardiac surgery can create problems at which site of the bundle of His. Traveling further down, the bundle branch and the fascicles. Now, once again, they are very nicely insulated. So this is a cross section. This is kind of little longitudinal. You can see that these are the bundle branches, and they are very nicely encased or ensheathed in a fibrous tissue. So they are electrically insulated, which allows the conduction to rapidly move down rather than lateralizing. So it is very nicely insulated. And then it ends in fascicles or the Purkinje fibers, which directly innervate the myocardium. Now, these Purkinje fibers have intercommunication with each other. So till now, the conduction system was conducting one way through the AV node, bundle of His, bundle branches. But the Purkinje fibers have a network in the myocardium, and therefore there can be intercommunication. It is important to note that the His bundle and the Purkinje system are not that well autonomically innervated like your AV node and the sinus node. Again, a very good picture to understand the bundle branches. Now, let's first talk of the left bundle branch, which is a continuity of the penetrating bundle further down, and it arises on the left side between the right coronary cusp and the non-coronary cusp. So that comes out here. And therefore, many times when we have difficulty in ablating the AV node from the right side, it is sometimes this approach, getting your catheter under the right coronary cusp on the septal aspect, can give you a relatively easy ablation of the AV node. That is an indication that you often employ for people with permanent AF to slow down the ventricular rate as a permanent rate control measure, obviously after which you put a pacemaker. Now, this left bundle is a little thicker structure, and then it branches out, as we all know. And what is non-controversial is that it gives a thin left anterior fascicle, which innervates the anterior papillary muscle here. And it gives a left posterior fascicle, which innervates the posterior papillary muscle. So this is well established that there is a thin left anterior fascicle and a thick and a wider left posterior fascicle. Now, I'm repeating this because the thinness and a cord-like anatomy of the left anterior fascicle and its presence on that anterobasal wall of the LV probably makes it more prone to a block or degeneration, and therefore you probably get left anterior fascicle block far more common than the left posterior fascicle block, because the left posterior fascicle is a little wider, it branches out, it's more interdigitating. So getting left posterior fascicle block is a little isolated left posterior fascicle block is a little uncommon. But there is another thing is that many of us would believe that there is probably a left posterior fascicle which either comes out as a separate branch or maybe a prominent branch from the left posterior fascicle. So there is also something, or there is also what we call as a left septal fascicle. So probably the left bundle branch has a trifascicular pattern of branching. Now, this is a picture from the important work of Professor Henry Culbertus from Liège in Belgium. And he, along with de Moulin, dissected the left bundle, and you can see that there is such a varying anatomy of the left bundles. These are left bundles from different individuals, post-mortem studies, and it shows that the left bundle has quite a variation in its size, number, and distribution. The only common thing is that it is a pretty broad structure to start with, and how it branches and how it interdigitates tends to be a bit variable, and this has its significance when one is doing what is called as a left bundle branch area pacing. Compared to that, and I don't have a picture, excuse me for that, the right bundle is a pretty thin and cord-like structure. It is relatively subendocardial on the septal aspect till it exits from the subendocardium and at the base of the medial papillary muscle. So this endocardial structure that the right bundle is, and a thin cord-like thing that it is, makes it very prone to transient injury, especially when you do a right heart catheterization. Many times you can easily injure the right bundle and create a right bundle branch block. This is transient, and it does, of course, recover, but it is more relevant when you kind of do a right heart cath in people who have a left bundle branch block, because injuring this right bundle, you can immediately have a complete heart block on table, and that obviously can create some panic. This emerges from the right bundle emerges from the base of the medial papillary muscle, traverses the moderator band towards the anterolateral papillary muscle, and then branches out into Purkinje fibers. The last area of the right ventricle to be activated is the right ventricular outflow tract. Now let's understand a bit about the blood supply of the AV conduction system. Now, the AV node, the proximal part of the AV node is largely supplied by the AV nodal artery, and we said that it comes most of the times from the posterior descending artery. But the distal part of the AV node and has a dual blood supply. Also, similarly, the bundle branches and the fascicles. The right bundle branch and the left anterior fascicle is supplied predominantly by the left anterior descending, whereas the posterior fascicle is supplied predominantly by the branch from the posterior descending artery coming from the right coronary artery most of the time. So the septal perforators are important for this distal conduction system being supplied. Now, some physiological aspects of the heart rate. Now, traditionally, a normal heart rate is somewhere between 60 to 100. And these days, many relatives, patients have over-the-counter instruments which measure the heart rate, and therefore you would often get these phone calls by measuring the heart rate now and then, sometimes a source of disturbance. But the increased heart rate is bad news many a times, because it increases the risk of adverse events, and low heart rate is generally associated with a better health and longevity. So sometimes if people have a higher resting heart rate, it is a good advice to them to correct on their lifestyle factors like obesity, sleep patterns, beverages that they take, smoking, a number of these things. So having a slow heart rate is better. I think we have number of instances in the animal world that, for example, a mice has a normal heart rate of 300 and lives shorter, whereas an elephant has a heart rate of 40 and lives longer. So a high heart rate, resting heart rate is not necessarily a good news, and that is even in disease. So for example, if you look here in this post-ACS patients, the in-hospital events and mortality is higher when the resting heart rate was more. So different numbers, say more than 90, more than 80, whatever. So a higher resting heart rate is not good news, and reducing or decreasing the heart rate would probably bring a mortality benefit even in a disease state. Again, for people, most of you would be reading Holters, and therefore you must know a little bit of circadian variations in the heart rate. Even some of you are working in the ICU, you're not perturbed by slow heart rates in the night because that is normal. Now, here is a little pictorial presentation. Heart rates are usually slow at night, so these are night hours. The heart rates are slow at night, therefore the PR interval is also a little longer, the QRS duration is a little longer, and the QT is a little longer. So that is the nighttime normal physiological variation, and the same parameters tend to be in opposite direction in the daytime. And that reflects also in the arrhythmias, the bradyarrhythmias, the Brugada manifestation, ER manifestation is more at night. Early morning incidence of sudden cardiac death is well known, similarly long QT, and PVCs can happen all through the day. When the exertion is peak in the middle of the day, you can have higher incidence of people getting ventricular arrhythmias if they have a catecholinergic polymorphic VT. So arrhythmias, normal heart rates as well as arrhythmias have a certain diurnal variation, and broadly speaking, that's how it affects the arrhythmias. With the age, the heart rate tends to slow down, and that's because the sinus node is a very high amount of fibrous and connective tissue, and therefore it significantly affects the sinus node early. And you do get, independent of the gender, fitness, and lifestyle, there is a certain slowing of the maximal heart rate that happens with aging. Again, that's important for when you are reading some of the devices. Let's come down to something about the functionality of the AV junction and the conduction system. So it is important to understand that the PR interval involves actually three segments: the intra-atrial conduction, the AV nodal conduction, and the conduction through the distal system, including the His and the bundle branches. Now, the major delay in all this happens in the AV node, and we discussed that it is physiological to permit the ventricular filling. If you understand this, if the PR interval is long, if your PR interval is longer than 300 milliseconds, the delay is usually in the AV node. If it is between 200 to 300 milliseconds, it's the intra-atrial delay that is responsible. It's something good to kind of understand how the AV node is kind of a speed breaker in this conduction system. Again, one more important aspect of the physiology is to understand that the AV node is actually a kind of a junction with different specialized anatomical structures. The inputs, it's like a rabbit. The head of the rabbit is the AV node, and the ears are the fast pathway and the slow pathway input to the AV node. And that difference in the pathways is probably they are anatomically different, or the ion channel expression is different, or the connection distributions are different. So there is a difference in the conduction. So at slower heart rates, probably the conduction happens more. The input to the AV node is more to the fast pathway. As the heart rate rises, the conduction happens more by the slow pathway. Now, this is fast because it is mainly sodium current dependent, which is absolutely a rapid way of conducting. The phase 0 has a very high velocity of inward sodium flow, whereas the slow pathway is mainly calcium current dependent, and therefore the conduction velocities are slow. Here is a pictorial representation. If you pace at a faster, shorter cycle length, that is at a faster rate, your PR interval tends to prolong. The reason probably is that when you are pacing at a slower heart rate, you are entering the AV node by the fast pathway. As you keep increasing the pacing rate, you enter the AV node by the slow pathway, and therefore your PR interval gradually prolongs as you move from the fast pathway to the slow pathway till you reach a Wenckebach point. Now, there is something called as a fast and slow pathway that can be elicited by what is called as a jump. So here is a normal PR interval. Suddenly, when the heart rate becomes a little faster, the PR increases by more than 50 milliseconds. So a sudden switch from a fast to slow pathway identified by a 50 millisecond increase is called as an age jump. And there you measure actually the age interval. Some of you might be curious to say that the heart rate does increase in the stress test also, but you don't see any PR prolongation or Wenckebachs. In fact, the PR interval shortens. The The explanation for that is that while the heart rate tends to stress the conduction system during a stress test, the autonomic tone increases, the sympathetic tone increases, and that tends to work in direction and it shortens the AV interval. So therefore, you have this shortening during the stress test. You are probably all aware of what is concealed conduction, where the conduction system normally is supposed to work in antigrade direction, but if you get a PVC, you have a retrograde conduction to the conduction system, and therefore the antigrade conduction is prolonged, and you get a PR interval which is longer after a PVC than the intrinsic PR interval. There are alternate pathways to enter sometimes from the conduction system. So we said the annulus fibrosus would not allow conduction down anywhere except the normal specialized conduction system. But you sometimes have muscular strands like this connecting from the atrium to the ventricle at different places, breaching the AV annuli. And these are accessory pathways, which all of you know is reflected by a short PR delta wave and a long QRS. So this is kind of a different thing. Coming to somewhat about the functionality of the conduction system, left bundle branch, we described that there could be left anterofascicle, left posterofascicle, and sometimes a left septal fascicle. And this is very well highlighted even by the activation patterns, is that the first activation of the ventricle tends to happen at 3 different sites, suggesting that actually there could be a trifurcation of the left bundle. And this, again, it is not a common knowledge that the branching out does not necessarily happen at the bundle branch level, but sometimes there are fascicles which are committed to become a right bundle or a left bundle even before the branching patterns happens. And therefore, sometimes if you stimulate above the level of the block, higher output, you can still manage to conduct and negate the bundle branch block pattern. Now, one must be thankful to the Argentinian School of Electrocardiology, and all of you as cardiology postgraduates should know the name of Mauricio Rosenbaum. What he did was he dissected the dog conduction system, and he could very selectively transect the left bundle, the left anterofascicle, and the left posterofascicle, and give us the description of how a left bundle branch block should look, how a left anterior hemi block should look, and how a left posterior hemi block should look. So they used to call it a hemi block, because in dog, at least, the conduction system really trifurcates, bifurcates as a left and right bundle and the left anterofascicle and left posterofascicle. So it is very distinct and discrete in the canine models, and therefore by transecting, you would create ECG patterns which could be described as a left bundle branch block or these hemi blocks. Unfortunately, this all could not be translated into humans, because in the humans, the conduction system is pretty interdigitating, and therefore you cannot exactly transect and produce those patterns. But this is one important concept I want to make all of you understand, is trifascicular block, right bundle branch block, left axis, prolonged PR. Does it mean that there is a trifascicular block? Is it hanging by the thread, meaning is a complete block, hard block going to happen very soon? Not, because this PR interval does not necessarily imply that the left posterior fascicle is blocked. The delay could be in the AV node, and we know that the delays in the AV node don't block very soon. Or it could be that despite all this delay, the interdigitating between the left fascicles don't allow a hard block to happen so soon. So it is not an automatic decision to believe that a right bundle branch block, left axis, and a prolonged PR means that they're close to getting a complete hard block. And therefore, unless the patient is symptomatic, one doesn't make an automatic decision of a pacemaker. Here is an understanding of the variation in the bifurcation pattern of the left bundle. So the left anterofascicle and then the left posterofascicle. So the left bundle branch has such a varied pattern of branching and distribution, is that you can achieve a so-called left bundle area pacing at a relatively broad area, and you could create different patterns which apparently are as good. You can create a left bundle branch block pattern when you do a left bundle branch pacing. Sorry, you could create a left bundle for anterofascical block pattern. You can create a left posterofascical pattern or left bundle trunk stimulation pattern. So there is a wide area in the mid basal part of the septum where you can, in different patients, achieve a successful left bundle branch area pacing. So this again attests to the fact that the left bundle branch is a wide structure, a differently branching pattern in different individuals, and therefore your conduction system pacing can probably be achieved a little easily than in the his bundle pacing. Here is some understanding of the distal part of the left bundle branch block. Most commonly, the interdigitation is what I want to impress on here, that the left bundle, left hand posterior fascicle branches and has an interdigitation, and therefore you can have re-entry in such a scenario, giving rise to what is called as idiopathic left ventricular tachycardia or fascicular VT, which is identified by right bundle branch left axis or a northwest axis pattern. Similarly, you could have a left anterior to posterior fascicular re-entry or a re-entry between the right bundle and the left bundle, giving rise to bundle branch re-entry tachycardia. So basically, there is a spider web of fascicular interdigitation distally in the conduction system, which can make it prone to re-entry arrhythmias. What is different about the Purkinje system is that it conducts very rapidly at the speed of about 2 meters per second. And therefore, it is also very highly excitable. And therefore, in disease states like ACS, you can have Purkinje related PVCs or VT happening from those PVCs. So the Purkinje system is much more different. The upstroke is faster. It does not have that phase 2 like a plateau phase, and it is very highly excitable. So Purkinje physiology and pathophysiology is again different, and that makes them prone to this kind of a PVCs in the ACS setting and giving rise to VT-VF. And these PVCs again coming from the Purkinje system can be ablated to give relief of VT storm. I think I'll stop. This aspect is quite well known. We can take some questions in the right. Thank you, Suchit.
Thank you, sir. So I think let's see first in the chat we have some questions or not. One question is there, why VF is much more common than AF? Much less common, sorry, than AF.
Yeah, we see VF is more common in the setting of an ACS or in a very diseased heart, whereas atrial fibrillation is probably a disease of the aging and the degenerative
Dr. Pillai, yes, here.
changes that happen.
Yes, sir.
Power, so Holter, one triplet only, nothing much, but MRI, significant amount of scar they have reported from KD. So I told him CRT-D will be better, CRT-D will be better. And I've also told him the cost, Leelavati, I told him, he asked me the options. I said, take Leelavati because Dr. Pillai also is there. Otherwise, Holy Family cost difference is around. Yes, so I've given. I told you decide which you want. If cost is not covered and if cost is
sure, on a different meeting.
Dr. Pillai, one second. Hello, Ashish, can you hear me?
Yeah, sure, I can.
Dr. Pillai, I'll call you in a minute. So I had a good lecture, but I had one point to make. You said that the Purkinje fibers do not have a phase 2. I was under the impression that the part of the conductive system, you know, they are like ventricular myocytes in terms of having a phase 2. So it's only the Purkinje fibers which don't have a phase 2, because the rest of the his Purkinje system has a action potential which is like a ventricle myocardium, I thought.
The phase, the sodium channel, the phase 0 is the most prominent in the action potential of the Purkinje fibers. That makes them more excitable and more prone to automaticity whenever there is an injury or more prone to triggered activity. That is what I largely meant.
Okay. No, I think your lecture was very good. And one point only I want to make before Rakesh takes over is that the variations in the left bundle, and this was also brought out well by 3D mapping studies in the 90s by the group of Professor Wellens and all, showing that in heart failure patients with LBBB and in even other patients LBBB is very heterogeneous. So all may show a ECG of LBBB, but their ventricle activation has many heterogeneous patterns.
Yes, probably therefore the site that you stimulate to create a synchrony may not be the same in every patient, and you may not achieve the similar responder status in every patient. You have to stimulate the late activated site, and this late activated site would be different in different patients. So yes, we had mapped the left ventricle in left branch, and the activation patterns are indeed different patients.
So I think we should go ahead, but before that, I think one question we'll take. In the chat box, there are two questions leading to heart rate. One question is that you have said that low heart rate is better. So why should not we use beta blocker for everyone? Something like that. Another is that in a young individual with a resting heart rate of 90, I think we should be worried or not.
Yes, so this is a general understanding. One should understand from that perspective is that if somebody for no reason has a 90 heart rate at rest, then one should look at what is causing it to be 90. It's preferable that he's at 60, 80. It does not mean that you may treat him with beta blockers, but there could be some simple lifestyle measures which I very briefly alluded to, like his sleep patterns or work patterns, or many of these are working for call centers and they have night duties, and so you have to smokers or obstructive sleep apnea or number of these things that need to be or alcohol intake. These things need to be attended rather than saying that if somebody young has a heart rate of 90, that you need to prescribe beta blockers to get it down.
Thanks, sir. So I think we should move forward to our next interesting talk, a very important talk, approach to a patient with syncope. So this will be delivered by Professor Rakesh Jadhav, who is a professor of cardiology in All India Institute, New Delhi. Sir, please begin.
Thank you, Suchit. Thank you, Ashish. And I think after a very interesting talk by Ashish, and really I have learned a lot, new things for anatomy. I'm going to tell you how to approach a patient of syncope, because it's a very common presentation. And the biggest problem of a syncope is that more you closely look the patient, more you see a lot of divertification, there are a lot of diagnostic dilemma, over treatment. So if you encountered a patient of syncope, as a cardiologist, what I believe that majority are the undiagnosed, and there are majority, not majority, but a few good number of patients who are overdiagnosed and overtreated. Just let us go with their examples and approaches and examples. This is a 43 years old male, history of syncope while playing badminton. He was a very senior business executive. There's no prior history of any illness. He was perfectly a normal person. All examinations were normal. ECG, echo, TMT, Holter, HUT, which has been done by us, is normal. I reassured the patient, but patient went marketing. Somebody has done the angio also, it was normal. Then MRI was done, it was normal. After that, they were very panicked of why he has a syncope. And practically, we are not able to make any diagnosis. And ultimately, what I write, that you just required an observation and your reassurance. Next, a 42-year again a male who has a syncope by playing football. There's no previous history, nothing else. All examinations were normal. And it was an ECG. And this ECG was done outside. And they thought that it's probably an ischemia. So they do angio, it was normal. But forget to see the ECG. And there was an epsilon wave. And this on MRI came out to be ARVC. And there's a family history of sudden cardiac death. Again, 32 years female. He has a 3 days back while catching bus. She has a syncope. All examinations were normal. ECG was reported normal from outside. Echo, Holter, TMT, everything was reported outside normal. Patient was reassured, and after a month, one patient died. And this was an ECG. And this ECG was reported normal by a physician, though it's a prolonged QT interval, very clearly seen. So sometimes these things is missed by the practitioner outside. So syncope is a symptom, not a diagnosis. So never write syncope as a diagnosis. Now, the recent definition of syncope says it's a transient loss of consciousness due to transient global cerebral hyperperfusion, which is characterized by rapid onset, short duration, and spontaneous complete recovery. The postural tone part of a definition was omitted recently, which we were taught that there should be a transient postural loss of tone also, but it is being removed from the definition of syncope. It's a very common in a general population. But majority don't seek any medical attention, especially in a remote area. Number of episodes of syncope during the patient's life and during the previous year is a strong predictor of recurrence. And recurrent syncope sometimes, if there's no obvious cause and patient has a recurrent syncope, is really seriously prejudicial to quality of life. And there's Almeida bimodal presentation. This syncope occurs mainly around 20 or in late 1780. Recurrence of syncope is also very common. So don't think it's not about 35% patient of syncope will have a recurrence in 3 years follow-up duration. How will you classify syncope? The syncope classification, the recent classification comprises of 3 types. A reflex, which is known as neurally mediated syncope, and in which vasovagal, situational, carotid sinus syndrome is included. Other is syncope due to orthostatic hypertension. And note that hypertension may be exacerbated by venous pooling during exercise also. So post-exercise, patient may have orthostatic hypertension also. After meal, they can have orthostatic hypertension. And invariably drug-induced, volume depletion, and primary autonomic failure and secondary autonomic failure. So these are classified as orthostatic hypertension. And third is in cardiac cause, which includes all type of arrhythmias and structural heart disease. If you go by number, majority of the syncope which is seen in a general population is neurally mediated syncope. But quite 1/3 of the patients with syncope is usually an unknown cause. We cannot find any cause in those patients. There's few conditions which are incorrectly diagnosed as syncope, which include epilepsy. Most common differential diagnosis is epilepsy, intoxication, and there's maybe a TIA, and a lot of drops attack, false attack, and maybe only psychogenic also. So you have to always differentiate between syncope and pseudosyncope. Again, if you go at data, the majority of person are having syncope, which is a reflex syncope. But as the age increases, majority of the patient will have orthostatic hypotensive syncope. Now, when you are a patient with syncope, you have to first answer 3 important questions. Is it a syncopal attack or not? This is first and foremost. Second, has the etiology been ascertained or determined? You are able to determine the cause of syncope. And third, are there any data suggestive of high risk of cardiovascular event and death in future? These 3 important questions need to be addressed in every patient of syncope. Why? Because if it is a cardiac cause of syncope, if you don't treat, don't recognize, the mortality in future is very high. There are a lot of risk stratification done depending upon the age, history, ECG, and it has been well defined that if you have more risk score, there is a high chances of having any cardiovascular event in the future. So if a patient comes, you have asked 3 questions, then how you evaluate these patients. The first and foremost is a very proper meticulous history. Believe it, a proper history gives 80% diagnosis of a syncope. And if you don't take proper history, you will always misdiagnose the syncope. So very detailed, I will tell you what history you need to take in these patients. A very good meticulous history is the most important. Then a common general physical examination. Always take blood pressure. In the first sitting, always take in 2 arm and feel lower limb pulse also. Always try to check to rule out orthostatic hypertension, to take standing blood pressure after 3 minutes. And if you think ECG should be the first requirement in all patients of a syncope. But based on these, any physical finding history, you can have lot of other tests to diagnose this syncope. These are some tests which are commonly advocated for diagnosis of syncope, which also include a good psychogenic evaluation of a patient. Now, the differentiation between syncope and non-syncopal condition can be achieved in most cases with a detailed clinical history, but sometimes it can be extremely difficult. The following question should be always answered. Was loss of consciousness complete? Was loss of consciousness transient? It's a very rapid onset and a short duration. Did the patient recover spontaneously, completely, and without any sequelae? Did the patient lose postural tone? If all answers meet, it is probably a syncope. But if the answer to one or more of these questions is negative, exclude other causes of loss of consciousness before proceeding with syncopal evaluation. This is a data from 7 population-based study shows that the proper history and a general physical examination identify a potential cause of syncope in around more than 50% patients whose primary disorder can be diagnosed by just a history and a general physical examination. You don't require a lot of advanced investigation to diagnose the cause of syncope. Now, the history alone may be diagnostic of a cause of syncope or may suggest the strategy for evaluation. You need to have a complete cardiovascular neurological examination, orthostatic vital signs, and examination of carotid disease is mandatory in evaluation of the syncope. Now, when you want to take history, what you want to take in history, that is very, very important. The first and foremost question need to be asked, what circumstances precipitated the syncopal attack? In which position, whether it was supine, sitting or lying, or what activity patient was doing, predisposing factors, that is very, very important, overcrowding, predisposing event like fear, pain. So how the syncope is precipitated should be the first question. Second is question about onset of attack, whether it is preceded by nausea, vomiting, abdominal discomfort, feeling of cold, or palpitation. Very, very important. Then come third question about this attack. Way of falling, skin color at that time, patient has duration of loss of consciousness, breathing pattern, tonic-clonic movement was there or not, onset of movement in relation to fall or tongue bite or defecation or urination. So during the attack, these questions need to be addressed. Third question about the end of attack, whether the attack ended with all these things. You have a urine and fecal incontinence, you have a nausea, vomiting, sweating, feeling of cold after the attack. So this need to be asked from the patients. And last, about the background of the patient. Is patient as having any past history of cardiac disease, neurological disease, metabolic disease, patient is on medication, and in case of recurrent syncope, information on recurrence such as the time from the first symptomatic syncopal attack and on the number of spells need to be known to the doctor if they are evaluating a patient of syncope. These three basically syncope, neurally mediated syncope. You will have an absence of cardiac disease, long history of syncope, recurrent syncope. Patient will tell that I am having syncope from last 15 years since childhood. Practically, they are all are neurogenic, neurally mediated syncope. After sudden expected unpleasant sight, sound, smell, pain, it may be nausea, vomiting, autonomous activation before syncope. It may be started with nausea, vomiting. During the meal or in the absorptive state after a meal, you can have with head rotation. So these all things indirectly suggest that it is a neurally mediated syncope. Orthostatic syncope is very important after standing up, after prolonged standing after exertion, postprandial hypotension when you are eaten and suddenly you get up and you have a syncope, prolonged standing, especially in a crowded, humid places, and presence of some autonomic neuropathy like your patient is having Parkinsonism. So these all indirectly suggest that it may be an orthostatic hypotensive syncope. And third, cardiac. Yes, during exertion or when supine, sudden onset palpitation preceded to the syncope, family history of sudden cardiac death, presence of any structural heart disease or ECG findings. So if you find this, it is probably a cardiac syncope. So by these important findings, we can differentiate between three types of syncope. Now it's recommended, the recent European guideline 2018, they recommended that always risk stratify a syncopal patient. So they have given low risk and high risk depending upon syncopal event. And in high risk, they define that the syncope is after a chest pain, breathlessness, abdomen pain, syncope during exertion, and when syncope is during supine position, sudden onset palpitation immediately following the syncope. So they have classified depending upon these criteria between high risk and low risk. And you should always read these criteria, very important, because a low risk patient doesn't require a very intensive investigation and management. But if there is any high risk feature in patient of syncope. They require a very thorough evaluation and a proper management because it can lead to sudden cardiac death. So this is very, very important nowadays to stratify. Certain important diagnostic tests like carotid sinus massage. Yes, we all believe that if a ventricle pulse lasting more than 3 seconds and a fall in systolic blood pressure more than 50 defines carotid sinus hypersensitivity. But the current guideline says that the carotid sinus massage is indicated in patient more than 40 years of age with syncope of unknown origin compatible with a reflex mechanism. That is very, very important. So if it is not compatible with a reflex mechanism, please don't try to do corrective sinus massage. And they say they have removed the criteria, basically class 1, that if after carotid sinus massage patient has a typical syncope, that it's a class 1, that the carotid sinus hypersensitive syncope is there. But if patient is asymptomatic and there is and the criteria was met, it is known as carotid sinus hypersensitivity. Orthostatic challenge tests like active standing or tilt testing. This is a if you have a symptoms suggestive of orthostatic hypotensive syncope, then if you have a symptomatic abnormal BP fall while standing, it's a very class 1 diagnostic criteria that these patients are having orthostatic hypotension. Active standing, intermittent determination of blood pressure after 3 minutes of standing, and if patient has a syncope or a symptoms, it is class 1 suggestive that the syncope is because of orthostatic hypotension. And the criteria, diagnostic criteria is given more than 20 millimeter systolic and more than 10 millimeter diastolic, and the decrease of a systolic blood pressure to less than 90, they all indicated that this is having an orthostatic hypotensive syncope. Tilt test, you all know that there's a 3 variety of tilt test: cardio-inhibitory, vasodepressive, and mixed variety, because the treatment of all these 3 varieties are different. This is an example of 18-year-old boy, a repeated episode of unconsciousness over 3 years. Examination, normal ECG, normal echo, normal Holter, treated with high dose of epileptic, continue to have the syncope. The investigation of choice is obviously in these patients is head-up tilt test, because nobody has taken a proper history how this syncope is precipitated, what was the prodromal during syncope, after syncope. So only the head-up tilt test is done, and it's a strongly positive heart test. So at present, what is the recommendation of tilt test? Now the recent recommendation has gone from class 1 to class 2A and 2B. Tilt test should be considered in patient with suspected reflex syncope. It was initially class 1 indication for doing tilt test. Now it is a class 2A indication for doing tilt test. I'm not going in detail of each and other investigation, but I am going to highlight certain point that how ECG is important in evaluation of the syncope. This is a lady. This is a lady, is about 60-year-old lady who has a syncope in a kitty party. She went to a kitty party and there she has a syncope and she recovered completely, brought to the casualty. The ECG was done. The diagnosis of acute ACS was made. Her angio was done. Angio shows about 50% disease, 60% disease. She was diagnosed as an ACS and told to start antiplatelet because the lesion were mild. Dual antiplatelet, again she has a syncope, but nobody has taken a proper history that patient was taking some medicine or not. And after taking a history, it was found that patient was having common cold since last 10 days. So she was on levofloxacin and she was on cetirizine. So obviously it's a prolonged QT interval. It's a acquired prolonged QT interval, and it's not an ACS. So proper history sometimes give you a very clear diagnosis of cause of syncope. Again, a Brugada syndrome. Now, I think by doing these all repeated seminars, ECG, the Brugada syndrome is diagnosed in periphery also. I'm very happy with this patient. This patient, Brugada syndrome, was diagnosed by an MBBS person. So I'm very happy that these all lectures are now the people are aware of ECG finding of syncope. This again a patient who has syncope during morning exercise, and this ECG was taken, and the MBBS, he was only in MBBS, he diagnosed the Brugada syndrome. So ECG gives lot of clue in some patients of syncope, like epsilon wave. If you know this, you can absolutely pinpoint the cause of syncope by just seeing this ECG, that it is an ARVC, nothing else. Why the Holter is important? Yes, sometimes Holter is important. You get a normal ECG. And this is a young patient, 14-year patient, recurrent episode of syncope. We have done an ECG, not found anything on ECG. His TMT was done. It was absolutely normal. We sent patient, one Holter outside was also normal because they only do a 3-lead Holter monitoring. We did not pick anything. But this Holter, when we find here, this Holter slightly suggests a Brugada syndrome pattern, and in same Holter we find that patient has an episode of ventricular fibrillation. He was treated with ICD and quinidine, and patient responded well. I think it's about 10 years follow-up. Now he's coming with no history of syncope, no true ICD discharge. Again, Holter sometimes give a very important clue. This young patient has a frequent VPCs, has a syncope, and on Holter we find VT. And the most important thing, all VT was initiated by a particular morphology VPCs. These VPCs was ablated, and the patient was practically cured of thing. History is also, if patient says that he's a syncope during exertion, don't forget a CPVT. That is very, very important. These are normal, is about 18 years old male patient, recurrent history of exertional syncope. ECG is normal, but when we subject this patient to treadmill, he has starting having polymorphic VPCs, ultimately led to polymorphic VT. Patient has a syncope during TMT. He was revived, and the diagnosis of cholinergic polymorphic ventricular tachycardia was made. He was given in a good dose of beta blocker. We have not given ICD, and I think he is on about 240 milligram of metoprolol at present. No symptoms, nothing else. So this is again a 62 years male patient. Sometimes over-diagnosis is also harmful in a patient. He has a syncope at about 3 a.m. when he was going to bathroom. He was thoroughly investigated. Echo was normal. His Holter was done. Holter shows these recording. He was diagnosed to have idiopathic VF, advised ICD. Unfortunately, this patient come to us. We have thoroughly seen this Holter, and we find that it's an Holter artifact, not a VF. It was just orthostatic hypotension. He was on antihypertensive drug at 3 o'clock in the night while going bathroom. It's very typical of orthostatic hypotension, and it was an artifact. So sometimes you should be very cautious in Holter artifact. We have seen in TMT and Holter artifact. So Holter artifact need to be seen thoroughly when you are making a diagnosis of ventricular fibrillation. It's all an artifact. Long term, sometimes what we need a long term monitoring by either an ELR or ILR. And now the indication of ELR and ILR has risen in a recent guideline to diagnose syncope in which you are not able to find any cause of syncope during initial evaluation. EP study, yes, EP study is always debatable, and there is now a very limited role of EP study in diagnosing syncope. Only in a patient with syncope and previous myocardial infarction or other scar-related condition, EPS is indicated when syncope remain unexplained after non-invasive evaluation. But I don't think if your EF is less than 35%, anybody is doing EPS. I think everybody is putting in ICD. Only a very limited, in a very mild LV dysfunction patient, no other cause is found, you may try to induce VT with an EPS. So these are the basic diagnostic yield. History and physical examination give maximum diagnostic yield in a case of syncope. Additional by ECG, by tilt test. So if you go that the diagnosis of syncope is combination of a history, examination, and investigation. I think 1 or 2 more slides is there. This is again a 64-year-old gentleman, history of transient loss of consciousness. He was NYHA class, LVEF is 45%. ECG is showing PR prolongation in LBB. Unfortunately, his EP was also done. EP only H intervals prolonged. Everything was normal. VT induction was done. It was normal. So sometimes you encounter these type of patient, but I always believe that if there's a very typical history of syncope, you have a LBB and PR prolongation, I don't think any further investigation is going to yield. Even if it is EPS is negative, these patients require pacing backup, and they improve in these patients. The lot of recommendation has changed from 2009 to 2008. Some indications are upgraded, some indications are downgraded, and some investigation has been omitted from the diagnostic evaluation of syncope. So if you go to recent guidelines, there are a lot of changes, but most important changes what they have done, that risk stratification of a syncopal patient to low risk and high risk. That is very, very important at present, which you need to evaluate in all patients. And if you go to American and European guideline difference, yes, American guidelines are less in implantable loop recorders. They are not very happy with implantable loop recorder by Europeans, that it's a class 1 indication if you are not able to diagnose. EP study, Americans are very less to do in EP study in evaluation of syncope, but European are more for EP study if not diagnosed by non-invasive methods. So you should always mind that the only difference between syncope and sudden death, that in syncope one can wake up. So you should be very cautious that syncope is should not be taken lightly. It's a common problem. A very careful history and physical examination give diagnosis in 50% of the case. It's at most important to take a good history. The test should be done judicially, not indiscriminately, because if you do more tests, you will become more confused. And risk stratification at present is must. Don't take syncope lightly until you have risk stratified these patients. Thank you very much for your time.
Thank you, sir, for that extensive and elaborate discussion. And it's very important topic for our juniors. I think everybody should mute except the speaker, moderator, and the faculty. Please mute yourselves. So, I think we have some time, a couple of minutes to discuss, and then we'll go ahead with the next talk. That is also maybe a rejoinder to your talk, because that is very important. The last thing which we discussed, that LVEV and prolonged period or something, you have syncope, but you don't have anything on the EP study, and still the syncope is occurring. So, sir, there is no questions in the chat box. I will ask you one or two small things. One is an elderly with a syncope. I have seen often these are polypharmacy related. What is your take on that?
Absolutely. Now I have changed my concept of treatment of blood pressure. All patient will buy a BP instrument and they will measure their blood pressure at home. What I have seen it, the patient comes to your OPD. You measure the blood pressure in my OPD after 100 patients fighting with everybody, the blood pressure will definitely rise. And we all know that in a normal person, there will be a difference of 30 millimeter systolic and 10 millimeter diastolic during whole of the day. So what happened? We catch the highest blood pressure. Suppose you catch 150/90 in my OPD, I increase the medicine. Actually, at home, the blood pressure is 110/70 because it's all because of atmosphere. So polytherapy, and I believe that 50% of our BP patients are overtreated. If you get, and second important thing is anxiety disorder. I'm fan of giving mild SSRI and anxiolytic in practically 50% of the patient of blood pressure, and believe it, their blood pressure which was not controlled come because you take, there's a insomnia, there's always stress related problems. So you are absolutely correct. The polytherapy for hypertensive patient is a very important cause of postural hypertension.
Especially one more small question, because we are really short of time. This is bifascicular block with.
So Sujit, Sujit,
yeah.
Sorry,
sir. Yeah.
So no, it was a wonderful. It was Rakesh with all his years of experience. From his starting slide till the end, it was a very, very informative talk. I have just 2-3 comments. Am I audible?
Yes.
Yeah. Please, others mute themselves, please.
So Rakesh's comments were excellent, but I still see 2 or 3 very disconcerting trends. And that is, every patient of syncope, by the time he comes to a cardiologist, 9 out of 10 times some brain imaging has been done. And no matter how much people rightly criticize cardiologists for doing angiography for any symptom. But I would say that I would rather criticize neurologists for doing brain imaging for syncope. There are very few neurologists who say straightforward, this is syncope, this is not seizure, and you don't require brain imaging, because I always say syncope is not a brain disease, period.
Absolutely, sir.
The second thing is history taking, and the way syncope is presented in the rounds is again very disappointing. The resident will say this patient had syncope, 2 episodes. The echo shows so and so. Finished. From history, it is straight to echo. The history is finished within 5 seconds. I think if you want to make a diagnosis of syncope, majority of it will be made on the history. And if you do all the points that Rakesh has enlisted, then you will not go wrong. You will not over-investigate. You will not unnecessarily investigate. And you will not make patients panicky. These are the 2 points that I wanted to make.
Absolutely
Yes, sir.
correct comment, sir.
So I think one more small comment and then we'll go. This bifascicular block with syncope, sir, Rakesh sir, can you just for the juniors and who are attending that when should we investigate and how much they should investigate?
The important thing is that bifascicular block on ECG is very common. It's not an uncommon disease. And the syncope in these patients, if you see the data, I have taken one lecture on this. If you see the data, the bifascicular block, if all patient of syncope is concerned, the bifascicular block is responsible only in less than 10% of the patient. Patient who has a bifascicular block. I'm telling about the patient who has a bifascicular block. Majority of these patients, syncope is not related with cardiology. It is either a neurally mediated syncope, and believe one thing, if a history of syncope is for very long, suppose patient has a history of syncope from last 10 years, I never believe that it may be because of bifascicular block. If it is the syncope is because of AV block or any conduction block, it cannot last for 10 years. That is very sure. So again, there's a lot of tendency to do an EP study in bifascicular block in a patient of syncope. That is also true. So I will always say take a proper history. If you are convinced that this syncope may be a cardiac in origin, then probably you can go for a Holter if you don't find anything. Before putting pacemaker, I will always say do an EP study, which has also probably 50-50 rule. EP study normal, what will you do? So I will say it is only your judgment, history will tell you that this patient require pacemaker or not in bifascicular block. Very difficult to comment in majority of the patient.
Thank you, sir. So we'll move ahead. I think that last question that we should do EP study and EP study is normal, then what should we do? So all these things I think brings to us to the third topic to be delivered by Dr. Ullas Pandurange, who is the Chief of Cardiac Electrophysiology in the prestigious Madras Medical Mission. So sir, I think you can begin your talk on paroxysmal AV block. Thank you, sir.
Thank you, Suchit. And let me share my screen.
Yeah. Not yet.
I think I'm
Yes.
green
So
and
full screen.
should be all right.
Yeah, excellent.
All right. Good morning, everyone. To begin with, let me thank Dr. Ashish Nabar for bringing me to this class. Let me also, on behalf of IHRS, place on record the appreciation and compliments to Dr. Ashish. The concept Sunday EP class is his idea, and he consistently, over the last 2 years, dedicated his precious time, brought fine teachers to the sessions without any break. And it's a fact that Dr. Ashish has brought a new and a very convenient and effective way of learning EP in the country. Thank you, Ashish. And of course, I'll have to thank Dr. Suchit Mujumdar for helping Ashish. Today, I will speak very quickly about paroxysmal AV block. Before getting into the definition of paroxysmal AV block, which is not universally accepted, let's look at the features of paroxysmal AV block. A paroxysmal AV block, often it is an event which is of abrupt onset and is usually pause-dependent block in the AV conduction. It is usually not preceded by slowing of the PP intervals or PR prolongation. It is often a manifestation of intra or infrahesian disease, and it is an uncommon cause of a syncope and sudden cardiac arrest. There is usually an evidence of distal conduction disease at baseline. For example, RBBB is more often seen, but quarter of the times the QRS could be normal. The etiology is attributed to degeneration and fibrosis of the cardiac conduction system, typically the Hesian and the infrahesian conduction axis, which could be also acquired in situations like infiltrative diseases, and sometimes it could even be a drug-induced event. The commonest mechanism that is attributed to paroxysmal atrioventricular block is the phase 4 block, which is seen in the deceased His-Purkinje system. Unlike in the normal His-Purkinje system, that is during the diastole, when the resting membrane potential remains quite negative, in the deceased His-Purkinje system, the cell membrane of the His-Purkinje system is leaky, and the sodium channels are leaky, and hence there occurs a gradual influx of the sodium current, which should not have happened. So at a time when the stimulus comes, especially when the stimulus comes later than that is expected, there are hardly any sodium channels which are activated so as to cause an effective phase 0 depolarization. So that is what is the mechanism that is most often attributed. An uncommon mechanism is, especially in those patients where there is no evidence for the conduction system disease, and that is attributed to adenosine deficiency. The low levels of adenosine make the adenosine receptors hypersensitive. And in occasions when the endogenous adenosine level increases, because of the hypersensitivity, there can be a prolonged duration of an AV block. And in such patients, there can be a beneficial response to theophylline, which is an antagonist to the adenosine receptor. The triggers are usually an extrasystole, which is causing a pause. For example, it could be atrial premature beat, ventricular premature beat, his extrasystole. In the absence of these extrasystole, there can be occasions where there can be a pause. For example, a termination of a supraventricular tachycardia, a carotid sinus massage causing a pause, a valsalva maneuver causing a pause, or even sometimes spontaneous sinus rate slowing, which will cause the diastolic depolarization and making the sodium current and not getting in large numbers to cause the phase 0 depolarization. So these are some of the triggers. Let's go one by one, the examples by these triggers. Let's look at an event which could be caused by a premature ventricular beat. For example, this is a 77-year-old female, normal echo and a recurrent syncope. If you look at this, there's a right bundle branch block, normal PR interval. Most likely this patient may be having the typical intermittent CHB. However, we just now understood that this is a suggestive of his or infrahesian disease, and hence the symptom could also be because of the paroxysmal atrioventricular block. So you subject this patient to telemonitoring or Holter monitoring, and then you find there are occasions when there is a PVC, and if there is a pause and there is a delayed sinus beat, and if that delay is of a critical delay, for example, here, the delay was about 2000 milliseconds, and the delay here is more. Maybe the prematurity of the PVC also determined when the next P is coming. So this critical increase in the timing of the P wave resulted in the diastolic depolarization in the His system, and hence this P did not conduct. And that goes on, and then, for example, here, 2,400 is, compare this 2,400 to 2,300. If the delay is less, maybe the occurrence of the pause is less. More the delay, more prolonged AB block. And what is also important to notice that these, during the pause, there is a sinus acceleration and not a sinus declaration, which could be suggestive of a vagal block. Let's look at how a PAC can result in a paroxysmal atrioventricular block. PAC could be conducted, and I will show an example, even when the PAC is unconducted, how it can precipitate PAVB. Let's look at this ECG. There is an atrial ectopy, and this atrial ectopy is conducted, but it has reset the next P wave, which now is happening later than the previous PP intervals. This delay, what is the pause, was enough to cause the AV block. Notice that the further PP interval is also almost similar to this PP interval. Now let's look at the blocked PAC. This is a PAC. The underlying His-Purkinje system is recognized by this little widening of the QRS and a little bit longer PR interval. So it could be considered physiological with this kind of a conduction system disease, that even though the ectopy came really relatively late, it is not conducted. But it was not a benign event. Because this did not conduct, what happened was there was a pause, and that pause resulted in the further P not getting down into the ventricle. So if the PAC is unconducted, and the resultant pause will result in the precipitation of PAVB. And if the patient is fortunate, at a critical time, if there's a stimulus arriving before the depletion of the sodium ions during the diastolic depolarization, if there occurs a critically timed stimulus, it may actually elicit a normal action potential, and patient might be fortunate to be revived. Otherwise, there can be a prolonged asystole and syncope or a cardiac arrest that might happen because of this paroxysmal atrioventricular block. Another example here, a tachycardia termination. The patient had a baseline RBBB. There's some kind of wide QRS tachycardia terminating, I think it's the P. And this patient has been on a EP table for the evaluation of this tachycardia, with tachycardia and a history of a syncope. Not only the tachycardia here, but the initiation of a PAVB was also considered to be responsible for the syncopal episodes. Notice here that there is a PVC delivered or a pacing artifact here, and this was at a critical time, and that is why it captured the ventricle. If it were to be delivered outside of this particular window, this ectopy or this delivery of the impulse might not have even captured the ventricle. Another example of a PVC, there is this PVC. What happened? The next P is delayed, and there is a pause, and there's a precipitation. Again, the patient was fortunate here is because there occurred one ectopy. For example, this is not the conducted beat. There's an ectopy which happened at a critical time, and hence patient might have had simply a giddiness, but not a syncope. And if this were to occur at any other window, still the AV block might have continued. So the recovery is dependent on when the extra stimulus occurs during the period of the PAVB. Occasionally, a sinus slowing may cause paroxysmal atrioventricular block, and that needs to be differentiated from vagal syndromes. For example, here, there is this conduction system disease in the form of a right bundle branch block in leftward axis, and a lady who is a senior physician in the city who had undergone an extended Holter monitoring. look at this long asystole. Nothing seems to be extraordinary here, an abrupt AV conduction block. And why that occurred? Notice carefully the PP intervals. This PP interval and this next PP interval, you notice that this is slower. And this pause was good enough to create spontaneous diastolic depolarization and non-effective sodium entry and non-effective phase 0 depolarization, and then the asystole. So what is happening here, there is a gradual slowing of the sinus, and during the asystole, you notice that the sinus has accelerated. So this effectively rules out the vagal syndrome. The slowing, well, could be because of the vagal, all right, but when the sinus rate accelerates and still there is no conduction, is against vasovagal syndrome, and then this is in favor of paroxysmal AV block. Another one by sinus slowing here. This patient is on a ILR. Look at the sinus node. As the sinus intervals prolong, the pause results in the paroxysmal atrioventricular block. Notice here that there's going to be a sinus acceleration, effectively ruling out the vagal syndrome. So it's very essential to differentiate between the paroxysmal atrioventricular block and the block that is due to the vagal syndrome. There are some atypical forms of paroxysmal atrioventricular block. For example, there's a typical vagal AV block, all right, but that pause might actually result in a phase 4 paroxysmal AV block. Hence, not all vagal AV blocks could be considered as benign. Atrial tachyarrhythmia, 1:1 getting into 2:1 because of a phase 3 block. That particular pause may actually result in a paroxysmal atrioventricular block. And adenosine sensitive AV block, and typically in those with the normal QRS or a normal ECG, well, it's another form of a paroxysmal atrioventricular block. Concealed excess, nothing is seen, and for example, concealed junctional extrasystole might cause the block in the upcoming P, and that might result in a pause, and that may cause a paroxysmal atrioventricular block. Sinus rhythm, for some reason, there's an intermittent 2:1 AV block or a slowing, is a pause, paroxysmal atrioventricular block. So these are all atypical forms. Sometimes paroxysmal AV block could be also associated with the intermittent CHP. For example, a 2:1 AV block going on and the patient develops intermittent CHP, and then there is a pause. And then when there's a recovery, the further piece may not be conducted, and there could be a prolonged asystole. So the death in CHP could be because of a prolonged AV block due to paroxysmal AV block. This is an interesting case where 57-year-old male, normal echo, recurrent syncopal episodes. Several episodes of a short duration, long duration have been recorded, but there's nothing which you could notice. Each such long asystole period is preceded by normal looking PQRST complexes, absolutely stable sinus rhythm. There's no change in the PR interval, but then there is an abrupt, prolonged AV conduction block, and it is very difficult to find out what could be the etiology. Is it because there was a concealed extrasystole at one time, so that this was not conducted, that resultant pause led to the phase 4 paroxysmal AV block, or is it an adenosine sensitive, or it is an unknown trigger? It will be very difficult to make out. Again, sinus slowing here continues to be same PP interval, just because there is 1:1 conduction here and there is a sinus slowing. That sinus slowing led to this PP interval is slower, and that pause was good enough to create a phase 4 AV block. This is another interesting case where there was a challenge And how do we go about this patient who had a recurrent syncopal episodes? Normal baseline ECG, however, there was cardiomyopathy. I think she had undergone coronary angiogram. It was considered to be non-ischemic cardiomyopathy, severe LV dysfunction. Her dyspnea was not a major issue, but she was having the syncopal episodes. Investigating her on a Holter revealed the following traces. What are those? Nice conduction, sleek URS, PR interval is within normal limits. But then there are occasional slight prolongation of the PR, and then there is a block. Well, it could have been a part of a Wenke bag, or it could be anything else. But what is important is when there occurred a further slowing of the PP, and then there is no QRS here, is because of this critical prolongation of the PP interval, which had led to this kind of a prolonged asystole. Now, the question here is, this patient with the lower ejection fraction of 35% syncopal episodes, can we just attribute to only to this paroxysmal AV block and give her a pacemaker, or should we give her a defibrillator? Well, ejection fraction 35% or lower, well, is an indication if there's a syncope. On top of that, one should remember, even if the ejection fraction is less than 35%, this kind of a prolonged asystole, especially in a sick heart, might actually trigger polymorphic ventricular tachycardia. There's another one, again, a dilemma here. Look at this particular event where there is an asystole, where there's a pause of about 2 seconds, PR. Maybe the PR was constant here, and abruptly there is this P is unconducted. This PP interval may or may not be similar, but here in another time in the same patient is very clear the PR interval is prolonging. But now the question here is, if the patient has got a QRS which is wider, and if this kind of a occasional abrupt unconducted P waves, this could be a marker of a paroxysmal atrioventricular block. And instead of considering it's a benign, one may have to investigate further, prolonged monitoring. Are there any more such episodes, and how they are related with the PP intervals or the pause that is because of unconducted beat we should be looking at. So whatever we consider that is suggestive of a vagal AV block may not be really very benign, because it may predispose to paroxysmal atrioventricular block, especially if the QRS is not normal or underlying heart is not normal. How do you manage? I think 12-lead ECG is an important thing to look at, whether there's an underlying conduction disease. But we went through some examples where a normal ECG did not essentially rule out the possibility of PAVB. Extended Holter monitoring, I think, is a must if the diagnosis is not clear. Carotid sinus massage is an important component when you are suspecting a paroxysmal atrioventricular block. Not necessarily in the evaluation of just the so-called neurocardiogenic syncope. Paroxysmal atrioventricular block could also be unmasked by carotid sinus massage. I think I have a slide to show that. The EP study has a limited scope, especially when that is associated with the pharmacological challenge, for example, adenosine. And if you have procainamide in the lab, you can unmask the His-Purkinje system disease. So EP study, it can expose the underlying conduction system disease, for example, at a slower rate. If you see the HV delay or occurrence of a bundle branch block, a pharmacological challenge, as I said, and a critically timed PAC or a PVC can be delivered to reproduce the AV block. However, the observations have low sensitivity and specificity, and hence EP study has a very limited role. Role of carotid sinus massage, I think, is interesting. I think we should be learning whenever you have seen some kind of an abrupt, unconducted P waves in your Holter. What is the usual vagal mediated AV block on a carotid sinus massage? Is just the slowing of the sinus rate, gradual prolongation of the PR interval, and that's before the block. But what is a positive response for a PAB is PP lengthening. Well, that could happen, but without the change in the PR interval. For example, here, from you have started from here, there probably occurred a gradual slowing of the PP interval. But what is important is there is no change in the PR interval. If there's no change in the PR interval and there's an abrupt AB block, that I think is more malignant than just the hypersensitive carotid syndrome. This is an interesting trace which tells you what could happen in the CSM if the patient is predisposed to paroxysmal AV block. Well, there had been a gradual slowing of the PP interval, all right, but what has remained constant before the abrupt block in the AV conduction is the PR interval, including the AH interval, remained the same. The HV interval remained the same. It is just that the HH interval prolonged, and that has caused the phase 4 block. So carotid sinus massage at the bedside can unmask the predisposition to PAVB. Role of pacing. Basically, paroxysmal atrioventricular block, if you are demonstrated in a patient who had a syncope, it usually tells intra or infrahesian conduction disease. Usually the QRS is abnormal. However, if you are shown abrupt, unconducted P waves, even if it's a normal, please consider that as a paroxysmal atrioventricular block, and pacing is the only definitive therapy. There's a limited role for theophylline, adenosine receptor antagonist, in so-called adenosine-sensitive PAVB. And I would like to reiterate, the so-called vasovagal syncope may indeed be a malignant PAVB. I think prolonged Holter monitoring is a must. Bedside carotid sinus massage could be an art which we should learn. Thank you.
Thank you, sir, for that excellent deliberation on different facets of the paroxysmal AV block. I think we are slightly short of time, so we'll just not any comments. I think Dr. Ajay Naik sir has commented one thing, that direct myocardial stimulation via EP system would capture the myocardium. The phase 4 block is applicable for his Purkinje conduction related ventricular depolarization. I think because of that case where you showed after ventricular tachycardia, there was some ventricular pacing, there was something in the EP lab. I think that you meant maybe. So I think the pause is most important, should be in the his Purkinje system rather than anywhere else. So even if there is a PVC, it should block, it should not go into the his Purkinje system. Otherwise, there should not be any. So I think we'll go ahead with the next presentation because of interest of time. So the next presenter is Dr. Deepak Padmanabhan. He is an assistant professor in the Jayadeva Institute of Cardiac Sciences in Electrophysiology, and he will be speaking on diagnosis and management of cardiac amyloidosis. This is also a very upcoming and interesting topic. Thank you, Deepak.
Thank you, Suchit. I hope you can see my screen. And
yeah.
In the spirit of T20, these are almost the slog overs, and we'll all try to see if we can get through some cases. Most importantly, in my opinion, amyloid is more of a question of clinical suspicion and diagnosis, and then starts the treatment of the same. The earlier you do the diagnosis in this disease, in the natural history of this disease, the better is the prognosis. And hence it's critical that we have a high index of suspicion for anything unusual. Given that it's a systemic condition because of the extracellular deposition of an aberrant protein, it's very important to realize that it can present with multi-system involvement, of which the heart is also one of the organs involved. So presenting to us, that is how the patient would present to all of us, with some unusual or a common presentation of a common clinical condition, and how to link it to the substrate is what we will try and attempt to do today. Again, this is not exhaustive, and our objectives for the talk are essentially to figure out how to do non-invasive diagnosis of amyloid using echo, CMR, pyrophosphate scans, hematologic assays, and we'll have a few case studies which will kind of highlight these for us. So routine stuff, echo. For echo imaging criteria, diagnosis of amyloid, LVEF is less than or equal to 50%. The fraction, MCF fraction is less than 30%. The regional wall thickness or relative wall thickness is greater than 0.42, E upon A greater than 1.5, deceleration time less than 150 milliseconds. The absolute mean global longitudinal strain is less than 15%, and relative apical strain is greater than 1. These are, again, hardcore echocardiography students or patients who want to be evaluated on the echo itself. These are your criteria. Sometimes you can actually take a look at these. This is your routine echo that you'll see. And when you're doing a routine echo, what are the red flags that you'll see? You can see a pleural or pericardial effusion. You can see a thickened right ventricle. Sometimes the valves will appear thick. Intraatrial septa will appear thick. You can have paradoxical low flow, low gradient AS. This is something that's done a lot of times. We kind of deliberate a lot upon low flow, low gradient aortic stenosis. And at this point in time, I think it's critical that we know that paradoxical low flow, low gradient AS, in 40% of these patients, there is ATTR amyloid. If you look at restrictive filling patterns, the mitral inflow Doppler, where the very small A is present, and this in fact is significant for a very high chance of thromboembolic risk in patients with amyloid. The pulmonary vein Doppler show reduced functions. If you go to the GLS or the global longitudinal strain, you will see a poor pump function, a poor reservoir function. So you are going to see a change. This is your normal curves. This is the decrease in the pump function and the reservoir function. So the storage function is down, the pump function is down in amyloid, as you would expect, because it's an extracellular deposition of protein resulting into poor elasticity. Going ahead from there, what are your targets for imaging? If you have the suspicion for amyloid, what targets would you use? You probably look at the ECG. There will be a inability to correlate what is LV hypertrophy on the echo with the ECG. There is a lowering of the voltages. Your Sokolov-Lyon index is going to be abnormal. Then you will see an increased LV wall thickness on the CMR or the echo, which then leads you to think, oh, let us look at a PET scan or a SPECT scan to figure out what's going on here. In the MRI, you will see high T1 signals. You will see an increase in the ECV, which is commensurate to the extracellular deposition of this protein, which in turn, if it's AL amyloid, can cause myocardial edema, positive PET scans, and you have got variable non-contiguous, non-coronary artery deposition of LGE, which crosses coronary artery territories. It can be deposited purely in the, it can be transmural, it can be diffuse. So going on from there, you look at what is currently the commonest screening technique for a suspicion of amyloid, the technetium pyrophosphate scans. These are readily available, relatively cheap, and essentially work on two principles. One, you are going to compare the uptake with that of the uptake in the bone. This is a semi-quantitative or the visual scoring that you will have when you look at what is the grading. Grade 1, where there is slight uptake, grade 2, where there is significant uptake, and grade 3, where it is actually darker than the surrounding bone. Or there are ways to grade it where you look at the ratios there, which in turn lead to a value of greater than 1.5 being suggestive of ATTR amyloid. Now, in just 2% of patients, you will have AL, which will show a positive pyrophosphate scan, but anything that is greater than 1.5, 1.6, 1.7 is more likely to be ATTR. The limitations of this are basically overcome by what is called as the floor beta Peer scan, which definitively gives you the diagnosis of amyloid. Again, PVP readily available, something that we use commonly, should be used before we think of a flow beta Peer scan. Now let us look at a few case examples, not to tell you how to diagnose, not to tell you how to treat amyloid, but where are you going to think that this is amyloid? So let's look at a common 2:1 AV block. You have a 65-year-old male presenting with recurrent episodes of TLOC or syncope. ECG shows high-grade AV block, CHB. Echo is suggestive of LVH. Now, most of the times we think, oh, this is just hypertension, old age patients. Septal thickness here is 1.5 centimeters. Ejection fraction is normal, but cardiac troponins are raised. You do a coronary angiogram just for the sake of it, you may find a normal coronary. Now, why are the cardiac troponins raised? Now, these are very high risk markers for the possibility of amyloid. You do not see significant LVH in this, although there are STT changes there. Now, the clinical suspicion starts when you have a heart failure or red flag symptoms. I'll come to that in a minute. Increased wall thickness greater than 14 millimeters in a male who is greater than 65 or a female greater than 70. Now, what are these red flags? And especially in our patients, you are able to see LVH, you have AV block, you have a 65-year-old male, and a Sokolov-Lyon index, which is less than 1.9. What is the Sokolov-Lyon index? Your typical criteria for figuring out what LVH is, V3 plus V6, giving you, sorry, V1 plus V6, giving you greater than 3.5 mm. In our patient, you do have AV block in the presence of increased left ventricular wall thickness. That is your single biggest criteria to raise the clinical suspicion of cardiac amyloidosis. And obviously so, when you have that, you go ahead, do your cardiac signal on bone scintigraphy, the technetium pyrophosphate scan, and make sure, because of the 2% chance of monoclonal gammopathy of unknown significance, you make sure that you have normal serum free light chain ratio and urine and serum protein electrophoresis with immunofixation, that they are normal. If they are positive, you may need to go ahead and take a biopsy. Unless they are positive, a pyrophosphate scan would be good enough to diagnose ATTR-induced cardiomyopathy. Now, this patient had a positive test. We were able to diagnose amyloid, gave us a better understanding into what is going to go on with this substrate in the future. Again, a lot of arrhythmias need to be treated on the basis of the underlying substrate. It will guide what interventions you want to do, how you want to manage them. I'll illustrate that with the next example. Now here we have a 35-year-old woman presenting with atrial fibrillation, recurrent episodes of atrial fibrillation, normal coronaries, normal ejection fraction, normal MRI, resistant to 2 AADs, and echo is suggestive of normal EF, no atrial enlargement. Now, given that she was resistant to 2 antiarrhythmic drugs, she was going back into atrial fibrillation. She was significant for symptoms. She was taken up for a PVI. Now, take a look at this map. This is a map of the left atrium. You can see the 4 pulmonary veins. This is seen from the PA view. This is seen from the AP view. And this is not something you would expect. The red actually showing scar. You can see the voltage is less than 0.1. And anything that is purple or pink rather is greater than 0.5. If you see, there are very few islands of pink all over the place. Majority is red or a varying shade of green and yellow. This is something you would not expect again in a patient who's having a non-valvular atrial fibrillation. Suspicion of atrial myopathy came in. We evaluated her for purposes of amyloidosis, negative for light chain overproduction. The pyrophosphate scan showed a HCl ratio of 1.6, suggesting that she had amyloid. Again, amyloid in such a young age, likely to be hereditary, not the wild type. We did send a gene evaluation, which came back positive for a heterozygous mutation. Again, this, even though it is a patient having a mutated or a familial amyloid mutation, it is amenable to therapy with tafamidis or some of the other medications. This was started in this patient. Her fib was controlled with her PVI. She doesn't have any other episodes of fib. This has been a 1.5 years that we've followed her up for. Case 3, a 54-year-old male presenting with recurrent attacks of syncope. TMT was done. TMT showed a value of 79% of the maximal age predicted heart rate. He had a sudden syncopal attack after exercise. Chronotropic incompetence was documented. STT changes were not seen. Intermediate probability for CAD. The referring cardiologist put in a CLS pacemaker in place. CLS is the algorithm that is used for probable vasovagal syncope. This was thought to be vasovagal syncope. Given that he had a syncope immediately after exercise, somebody did a pacemaker for him. But the patient continued to have symptoms. There was progressive shortness of breath, deterioration to as much as NYHA class 3. MRI could not be done because the pacemaker was in place. We went ahead and did a global longitudinal strain. This is September 2021. This is March 2022. And as you can see with the blue, there is a reduction. The blue suggests that there is a reduction. It's a positive value, strain is usually negative, red is usually good. Wherever you start seeing blue, you are progressing to poor strain. And you can see there is a reduction in the strain values that have been noted. This led us to think there is something abnormal going on. Again, we did our pyrophosphate scans. Pyrophosphate was negative. We did autonomic function testing. Autonomic function testing showed predominantly sympathetic overactivity, showing definitive involvement of the autonomic nervous system. You can see the 10 minutes heart rate plot. You can see how changes are there. And we went ahead with the immunofixation tests, where we did find that the kappa and the lambda light chain were significantly overproduced. So if you look at the interpretation, a high kappa free light chain, a high lambda free light chain with a normal ratio suggesting of biclonal gammopathy of free light chain type. This was diagnosed for this patient, underwent a bone marrow transplantation, is doing relatively well, but there has not been any reversal of his cardiomyopathy at this point in time. Again, indicating that perhaps had we done it better before he went into class 3, we would have been better served. Going on from there, case 4. Another kind of challenging case for a lot of people. Known case of diabetes. Presented with paresthesias, EMG was done, suggestive of lower motor neuron neuropathy. Then started developing weight loss, cervical lymphadenopathy was found, did a biopsy, found granulomatous lymphadenopathy, ATT was started. Patient then presented with foot drop. Nothing was suspected. She presented to the cardiac ER with NYHA class 3 shortness of breath. LVH was present on echo. As you can see, there is a clear dissociation. ECG does not show LVH. Normal coronaries, but elevated troponins, elevated BMP. Exudative pleural effusion was present in this patient. Anemia was present. Went on, further got evaluated. 30% plasma cells with increased lambda light chains. Smoldering multiple myeloma. No treatment by guidelines. Managed with diuretics and SGLT2 inhibitors. Even at this point of time, there was no diagnosis of amyloid made. Responsive to torsemide, which was greater than furosemide response. Again, a characteristic of patients presenting with amyloid-induced heart failure. Then presented to EP with recurrent monomorphic outflow tract PVCs and occasional episodes of atrial fibrillation. Set us thinking, multiple myeloma, smoldering, why is amyloid not being considered? Was being evaluated when she developed hoarseness of voice, progressive dysphagia, wasting of palmar muscles, developed MND, needed the placement of a PEG tube, and at that point of time, fat pad biopsy was taken, which was suggestive of amyloid. Now, the question here is this AL amyloid or ATTR amyloid? All common sense points to AL amyloid, definitely true, but what needs to be remembered is that just because there is overproduction of light chains, ATTR amyloid still can be commonly present in these patients. Immunospectroscopy confirmed the presence of AL amyloid though for this patient, but statistically ATTR can also be there. The reason why I stress upon this difference is ATTR amyloid and AL amyloid treatment courses are extremely different. And AL amyloid is very, very aggressive in the way it progresses. This again is the one that we discussed. Always get our suspicion in place. Then when we do the pyrophosphate scan, simultaneously do send the light chain assays to ensure that there is no overproduction of the light chains. And if the ATTR is positive, if the pyrophosphate scan is positive, you are getting diagnosis of ATTR in the absence of light chain overproduction. In the presence of light chain overproduction, you then want to evaluate for a gammopathy and the sites for it. If the ATTR is positive and you want to further evaluate the patient, genetic testing will differentiate between a wild type mutation, which can happen spontaneously in the patient, or a hereditary amyloid, which can be through generations. If you take a history, you may come across these family members who've had progressive heart failure. We have 2 such families on which we are following up at this point in time. Going ahead from there, how do you prognosticate the patient? Even if you make an early diagnosis of amyloid and the patient is not affording therapy, prognostication is based mainly upon the troponin T and the NT-proBNP. As the levels of both rise, the outlook worsens. And this is something that we need to know, that in these patients can present with troponemia. High troponins in elderly patients, you have to think about a possibility of amyloid, especially if there is no sequential rise in troponins and or if the coronaries are normal. Going on from there, and perhaps my last case is something that you commonly see. 75-year-old male, dyspnea on exertion, angina, 2 episodes of syncope, echo suggestive of severe aortic stenosis with a DVI of 0.23, Vmax of 4.5, thickened aortic valves, normal ejection fraction. What are the chances that this patient has amyloid? This is the study that was conducted at the All India Institute, where they looked at 72 patients of screening, excluded 26 patients, 15 patients refused surgical aortic valve replacement. And when you look at the surgical aortic valve replacement patients of N of 46, they did histopathological correlation of the aortic valve and the basal interventricular septum, of which 33% were Congo red positive, 19 of them were TTTR positive, namely 41% of all these patients presenting with aortic stenosis and a low gradient low flow or even non-low gradient low flow were positive for cardiac amyloidosis. Again, isolated valvular amyloidosis was also present in these patients. Pyrophosphate scan was possible in 32 of these patients, where there was a significant positivity or a grade 3 uptake in only 9%. At 1 year follow-up in myocardial ATTR with cardiac amyloidosis, you had a death percentage of 3%. If you have myocardial ATTR CA plus death, it was around 33%. So it is not uncommon even in an Indian cohort. We need not actually look to a Western data for this. We have something similar here. And I believe registries in the future will only shed more light on this particular condition. The RACE criteria is a criteria which was presented in patients with aortic stenosis, which allowed us to see or suspect screening for cardiac amyloidosis, namely bilateral carpal tunnel syndrome, increased wall thickness, higher age, a very high E/A ratio with a lowering of the A wave, right bundle, low voltage ECGs, and a high troponemia. There is the RACE score, and as the score goes on increasing, the specificity and the sensitivity keep changing. Again, is it beneficial for a TAVI patient on an aortic stenosis with low gradient, low EF to undergo TAVI, or are they going to do badly? The benefit is actually significant, and they do just as well as in patients who undergo TAVI without cardiac amyloidosis. Again, a lot of you know that we do like to prognosticate and pre-diagnose cardiac amyloidosis. And this was an example using artificial intelligence, where on the basis of a single ECG in sinus rhythm, without any apparent features of amyloidosis in that patient, when you looked at these patients and matched them with controls, you were able to get an ECG algorithm which predicted amyloid well before the clinical features which we are used to and on the onset of heart failure. Perhaps greater widespread use of this algorithm will help us to pre-diagnose amyloid than what it is right now. The reason why I stress upon diagnosing amyloid early in the natural history is because the current cardiac amyloid medication approved by FDA does not change the deposition of amyloid, which has already been deposited in tissue. It just changes the solubility of the protein and prevents further deposition. But if the deposition has already occurred, there is no way to reverse that. So the existing pathology at which you diagnose the condition will remain for life, and that is what you need to manage. Once again, in summary, therefore, amyloid is ubiquitous and it's a force multiplier, just like a lot of other conditions for underlying cardiac diseases. Multisystem involvement is an important suspicious factor. Coexisting atrial fibrillation needs anticoagulation. You cannot apply the CHADS-S2 value to these patients. Doing aortic valve replacements, either surgically or by percutaneous techniques, reduces mortality despite the presence of cardiac amyloidosis. It definitely needs to be ruled out in patients presenting with heart failure and preserved ejection fraction. Syncope, especially in the middle age, unusual. Typical reflex syncope is the younger age female who presents with recurrent attacks of these. Happens in the middle age, even in the presence of diabetes. We need to do autonomic function tests to rule out the presence of coexisting autonomic neuropathy, which will then present with two system involvement, perhaps triggering the diagnostic workflow for amyloid, and requires very close evaluation. And finally, coexisting hematological disease, namely monoclonal gammopathy and ATTR actually happening is possible. Thank you for your patient hearing. Love to take some questions.
Great, great, as always. So I think, Deepak, that you have already covered, I think, everything, every aspect of amyloidosis. So just a usual question, and I think great to meet. So patient with a syncope in an amyloid, no, how will you manage that? That is the problem. It's a practically speaking patient, maybe taking some therapies, maybe AL amyloid. Often we get AL more because we don't do other spider phosphate. So what will you tell them to do?
The unfortunate thing is, if you've already got autonomic neuropathy set in, you've got to treat just like autonomic neuropathy has been treated. There is no current drug that is going to change values. There are recent involvements of, there are recent class phase 3 trials which are going on for neural involvement in amyloid, which may or may not change the way we manage them in the future. But at this point of time, you have to manage them exactly in the same way that a routine syncope is managed. Because we don't want to worsen them. That is where we need to figure out if the patient can even afford these kind of medications. So early diagnosis, hopefully patient-centered management, and treating before there is significant damage remains the key aspect of these patients.
And often they may have a AV block also during the event. Then this gets complicated. Should you put a pacemaker? Should you put
Absolutely.
an ICD?
I have no doubts in my mind. I have no
What
doubts
should
in my
you do?
mind, Suchit, that you definitively need to put pacemakers in these patients.
Not ICD?
Sorry?
Not
No.
ICD?
Absolutely not. The guidelines don't state that. There is no documentation that there is going to be increased ventricular arrhythmias. The commonest presenting arrhythmias in patients with cardiac sarcoidosis is actually atrial fibrillation. That is where we are kind of looking into. There has been an IHRS grant that the IHRS Executive Committee has released this year for evaluating the presence of amyloidosis in patients with atrial fibrillation greater than the age of 60. This is something we still need to know, and we need to get data from our own place. We do know that the Western data suggests a possibility of 1 to 2%, but I fear the prevalence may be more commoner in our group of patients as compared to the Western world.
Yeah, because this AV block thing, I have noticed that if you put a pacemaker also, the patient may not survive. Because often there is a coexisting severe hypotension associated because of autonomic dysfunction. So pacemaker may not be the option, but you can put also that way. Yeah.
See, I would be very skeptical regarding data on it. It all depends upon what is the cardiac involvement of the amyloid. There is a score that is given by Dr. Martha Grogan where she has divided cardiac amyloid into 3 stages. So the involvement of the heart will definitely determine what the prognostication is and our involvement in terms of how much are we going to do for the patient.
Any other questions, Ullas sir and Rakesh sir?
No,
Yes, sir, put it there.
it's not the question. The comment is, of course, the talk was great. You see, when in day-to-day life, we'll have to be looking at the kind of investigations, what you would recommend, and what is the outcome of that. For example, the kind of scannings and the other tests that are involved to dig out the amyloid would have been appropriate if there is an effective and easily available and affordable medication. So unfortunately, because there is no specific drug which is affordable and widely available, this entity, I think, for some more time is going to be kind of an investigational arena. It's a research area. So I think all the institutes who are able to, kind of perform these tests freely for our patients, and if there is going to be a large registry from various institutes, I think we can contribute to the science of amyloidosis.
Great, sir. So we'll just shortly take 1 or 2 questions and then stop it. So one question is that if a patient has tested positive for both AL type and ATTR amyloid, is it what should be algorithm?
You would always want to hit the AL first. AL has got a definitive treatment role. Go ahead, do a bone transplantation, involve your hematologist in managing that. Absolutely very critical to get your hematologist involved in AL type of amyloidosis as early as possible, because it has got a mortality that is very high within the first 6 months of diagnosis. ATTR is relatively slow progressing. The patient will kind of gradually undulate and go forth. Depending on how much of the nerves are involved, that will determine the quality of his life. But AL amyloid, very fast progressive. Kidney failure is very common. needs to be evaluated and managed very, very early.
Okay, so I think in the interest of time, we'll just close today's webinar. There were excellent talks by faculty, starting from Dr. Ashish Nabar, Professor Rakesh Jadhav, Dr. Ullas Pandurange sir, and Deepak definitely, my friend, and also he is very well described this thing of amyloidosis. So I think I will thank everyone who has attended, faculty, including the students. It is very important, the PGs who have attended and stayed for this long. So I think we can conclude the webinar now. It has been great. Next webinar again, the date will be announced soon. So next month we will have another webinar, which will be again done by the EC members mostly, I think. Thank you, everyone.
All right, Suchit, thank you very, very much.
Thank you. Thank you.
Sure.
Thank
Deepak,
you. Thank you. Deepak, thank you. Bye.